All right. Thank you all for joining this evening, and we of course thank Pfizer for sponsoring this webinar. Our webinar presenter this evening is Dr. Mario Mendoza. Dr. Mendoza is a clinical anesthesiologist and the medical director for the opioids portfolio within the U.S. Medical Affairs Group at Pfizer. He completed residency in anesthesiology at the University of Miami and served as a medical officer at the Center for Devices and Radiological Health within the FDA. His role at FDA included serving as a medical device consultant, device researcher, and application reviewer and approver for medical devices. Dr. Mendoza also practiced as an anesthesiologist at the National Institutes of Health. Prior to attending medical school, Dr. Mendoza performed molecular bench research and managed phase 1 clinical trials at Abbott. He earned his Bachelor of Science degree in chemistry from SUNY College at Old Westbury and Master of Science in Organic Chemistry from the University of Illinois at Champaign-Urbana. He also earned his medical doctorate from the University of Illinois at the Chicago College of Medicine. Dr. Mendoza, we'll just turn it over to you.
Well, all right. Thank you, Jim, so much, and welcome everyone. And thank you for having me. And I'd like to thank everyone who's on the webinar on behalf of Pfizer and U.S. Medical Affairs and our pain team here. So happy to be on, and I hope to deliver a lecture that's of some value and provide some new data or hopefully insights which you're not already aware of. So a quick overview of the deck or my presentation tonight before I get started. So we'll start with the pain conundrum, right? And so that's the management, or I should say the adequate management of pain, not the under-treatment of pain, but adequate management, and that balance with trying to minimize misuse, abuse, and diversion. And now I'll define for you what misuse and diversion is. Apologies for those of you on the call that are already familiar with these terms. May be difficult to keep up because different institutions define them differently, especially recently with the CDC guideline, FDA guidance, and SAMHSA, or Substance Abuse and Mental Health Administration data that has just come out. So different definitions coming out of those groups. But anyway, we'll go into chronic pain. Quick definition of it: the cost of pain and cost of abuse, which I'll verbalize. The cost of abuse is not on a slide. I don't like to overwhelm too much with too many numbers on slides and take focus away. We're going through a patient case then, and really at the end of that case, I'd like hopefully some audience participation and see what your approach would be to this pain case that I'll present. We'll go through opioid abuse and adverse health outcomes and routes of abuse per opioid molecule, which you may be surprised to see how they differ or perhaps don't differ, depending on your expectations or your experience in clinic or in a hospital environment. And then a quick overview of currently implemented interventions targeted at reducing opioid misuse, abuse, and diversion. A quick run through of the FDA guidance on abuse-deterrent opioids. And I'll verbalize for you what the marketplace currently looks like. I'll stay away from brand names. I think it's probably the best thing to do. But again, towards the end of the presentation, I'll give you a chance to give me some feedback on what your management of that pain case will be if I'm sure you've seen a patient like this, or what your clinic or your hospital has currently implemented in terms of interventions trying to reduce opioid abuse. So thanks again for having me, and thanks for the very kind introduction. I realize maybe Dr. Mendoza was said too many times, a little bit my fault on there, Jim. So thanks very much. It's very awkward to hear too much about me. So let's move on to something that's not me. So Rethink Chronic Pain, what does it state that? This is a deck and content and material that we put together here at Pfizer. In terms of the approach to Rethink Chronic Pain, it's not anything that Pfizer has invented, and certainly nothing new. And it's along the lines of multimodal analgesia and appropriate pharmacological treatment of chronic pain patients. I won't be covering anything on acute or subacute pain tonight, just so you know. So again, according to the Institute of Medicine, pain patients across the board, and that includes acute both and chronic pain, are undertreated, especially the underrepresented minorities or African American and Hispanic populations. So trying to adequately treat pain, again, while minimizing the risk for abuse, misuse, diversion, and subsequent adverse health outcomes, such as overdose and overdose deaths, is quite a challenge, because at the end of the day, beside one condition that I'll show you, which I'm sure you already know, that is worsened with opioid treatment, at least in the chronic or long-term way, other conditions really do respond to opioids, as you already know in your own practice. Whether it's in a PACU, whether it's pre-op on an outpatient basis, opioids do work. They don't necessarily work all the time for all conditions, but overall they do work, and it's one of the best tools that we've got. So that's why we are currently in this opioid abuse epidemic. The epidemic as it stands now has a lot to do with prescription opioid and overdose deaths. So according to the CDC, for 2014, there were a bit over 18,000 prescription opioid-related overdose deaths. And so that's on par with HIV-related or AIDS-related deaths. If you look at another number for the CDC, on average, there are about 70 overdose deaths daily. But of those 70, about 40 to 45 are from prescription opioids alone. The rest will include, of course, illicit drugs such as heroin. So there's a lot that stands in our way in wanting to adequately treat in our attempt to minimize these adverse events, and really, at the end of the day, to not have anyone overdose on these opioids, whether they've overdosed by holding their own prescription or through diversion. And as I said, I'll define those things. So let's start now. So for misuse, actually, I don't know if, Jim, if you can unmute the mics. I'd like to hear maybe from the audience if anyone has any thoughts on the definition of misuse or what they've heard.
I can unmute them, but if I unmute everybody, there's going to be a lot of noise. If you can ask the question and ask people to raise their hand, I can unmute anyone whose hand is raised.
Okay, let's do that. So let's hear from the audience what you think the definition of misuse is. And I can't see the hands raised, Jim, so go ahead and pick whoever you'd like.
I'm just looking right now to see if anybody's raising their hand, and I don't see anybody.
Okay, so it's a little late. I'll forgive you guys. I know maybe the caffeine either wore off or hasn't kicked in yet. All right, we'll keep going, so no problem. So why don't I define it for you? Not a problem at all. I realize it's a bit late, unless you happen to be calling in from California. So anyway, misuse, as defined in the literature from 5 to 10 years ago, Lynn Webster, his own book and is a long-time chronic pain practitioner, defined it as a therapeutic use, however, not as prescribed. Okay. The NIH will define it as as used in an inappropriate way. The FDA, however, in a recent publication regarding abuse-deterrent opioids, really defined it as abuse, right, which is a non-therapeutic use, and definitely not as prescribed, non-therapeutic. And or SAMHSA, I should say, the Substance Abuse Mental Health Services Administration, who puts out a national survey on drug use and health, includes mental health, alcohol, tobacco, illicit drugs, prescription pain relievers, as well as anxiolytics and sedatives. They've defined misuse most recently in their 2015 survey, really inclusive of abuse and both therapeutic use. So for example, what I mean by therapeutic use other than as prescribed, it's simply as taking an extra pill on a Saturday instead of your 3 times a day pill, let's say. You take a 4th simply because you played softball, your knee hurts if you happen to be an active chronic pain patient, and that would be considered misuse, therapeutic use, but other than that's prescribed. However, keep in mind that when someone states misuse, it could also include misuse besides therapeutic use or both.
So I define misuse for you. Abuse is pretty straightforward. Diversion is simply taking a drug from legal channels to illicit channels. Or we're taking a drug for which we have no prescription. Okay, so for example, I leave an opioid in the medicine cabinet and my little brother takes it. Officially, that would be diversion. So I'll explain later on why that's critical and what data we have on that leads to abuse. So again, managing chronic pain patients while balancing the adverse health outcomes associated with opioid treatment is our challenge. I'm sure everyone on the phone is aware of the definition of chronic pain. Usually it's at 3 months or more. Somewhere between a month and 3 is subacute pain, and usually acute is anywhere between a month to a month and a half. The recent CDC opioid prescribing guidelines define chronic pain and chronic opioid treatment as 3 months. The guideline, as a side note, is really geared towards primary care physicians, physician assistants, nurse practitioners, and internists as well, not necessarily for pain specialists. But it is for the outpatient clinic and outpatient care of chronic pain patients. So let's move on to the cost of chronic pain. There are about 100 million estimated patients with chronic pain nationally, and the cost is somewhere between 550 to 650 billion. What's not on here is the cost of opioid abuse, which is roughly 55 billion according to a recent publication. About half of that is healthcare costs, and about 10% of that are criminal system associated costs. The rest of that is presenteeism or absenteeism, or really loss of work output. So let's go on to our patient case. So this is an elderly 75-year-old male with osteoarthritis, post-back surgery. Okay, comes in, or he has a chief complaint of chronic low back pain, a history of AFib, and a history of GI ulcer. The patient is on a novel oral anticoagulant, okay, or direct oral anticoagulant, which is just the next generation of warfarin, blood thinners. A history of NSAID use, and for pain, he's only on ER morphine. Okay. So part of this clinic, or at least at this pain clinic, we implement opioid risk assessment tools. Okay, so we test negative on opioid risk test, which is a quick test of about 10 to 20 items, assessing at the end of the day his risk for opioid abuse. Then there's a PHQ-4 and 2, which really assesses depression and anxiety, which have relatively high sensitivity for predicting opioid abuse. Okay, so he tests negative on all of those, including the urine drug test, which he gets every month on every visit for his ER morphine. We also checked in a prescription drug monitoring program for multiple prescribers and RNA. However, this month, this patient did not fill out the SOAP-R, okay, which is another screening questionnaire for pain patients for opioid abuse. It has high and low risk scores. It's about 24 items. And just like a lot of this opioid risk tools, it asks, did you take the medication for sleeping, for the control of your emotions, for relaxation? Have you ever had the urge to take more medications, and so on and so forth? So really assessing, again, the risk for opioid abuse. According to the patient, he's on morphine 20 twice a day and does well. However, even though you've been seeing him for a little bit over a year, this time he's short on pills. Okay, the clinic gave him a call, told him to come in within 2 hours, and we're going to count his pills. The patient was astounded and confused. He had no idea why he was short on pills. We'll come back to that. Let's go into the pain treatment first. So there are 3 main types of pain that you'll see in the literature. The last one to the right in blue, sensory hypersensitivity, may also be called the mixed pain state or central sensitization. But typically nociceptive pain and neuropathic pain you'll see as is. You can see examples under each one, and I won't read each one to you. But the approach in rethinking chronic pain, again, nothing new. It should be treating to the type of pain, treating, and when I say treating, I mean pharmacological treatment to the pathophysiology. So within these three chronic pain conditions, I mentioned there are also mixed states. Chronic low back pain often is a mixed state. Usually it's from trauma, but sometimes it can happen spontaneously. Okay, so focusing on sensory hypersensitivity, and that's the blue on top. You see fibromyalgia as the first bullet point. So just keep that in mind for moving forward. Okay, so according to the three types of pain in the top row, you go down to the bottom or middle row, and you see that first-line treatment is non-opioid. Right. Now keep in mind, we're only covering pharmacological treatment tonight, not all types of treatment. So we won't go into exercise, acupuncture, or cognitive behavioral therapy, or so on and so forth. We're just focusing on a pharmacological intervention. So you have a group of NSAIDs, you have anti-epileptics, SNRIs, and tricyclic antidepressants. So those are per guideline recommended for all three types of pain. You notice that opioid use is not recommended as first-line treatment. And opioids, if you look on the bottom right, under sensory hypersensitivity, or that column, you'll notice that opioids should be avoided. So the example of that would be fibromyalgia. So in fact, as you may already know, opioids worsen the pain in fibromyalgia and cause hyperalgesia. So the guidelines that I mentioned before, it's a list of about 12 or 13, excluding the CDC guideline. And you'll notice that for opioid treatment, or under the topic column for opioid use, you'll see that they're all second or third line. Okay, so opioids, in alignment with the CDC opioid prescribing guideline 2016, is not to be used as first-line treatment according to these guidelines. But in fact, what we see in some relatively recent data is that a lot of patients, just a bit under half, if you notice that green bar to the right, are treated with opioids as first line for fibromyalgia, which is a sensory hypersensitivity condition that I just mentioned may be worsened with opioids. So that's why this education is necessary, not necessarily to tonight's audience, but in general. That green bar to the right for FM, for opioids prescription, should be 0. So what are the adverse health outcomes of opioid prescribing and opioid treatment? If you look on the left side, opioid prescriptions have increased logarithmically in the last 20 years. Okay, so in those 2 decades, it went from 76 millions to 219. If you look on the right-hand side, temporally associated with that, of the increase in opioid prescriptions, is an increase in overdose deaths and opioid-related ED visits. So the overdose deaths comes from CDC data. The ED visits that are opioid-related comes from SAMHSA, which operated the DAWN network, which is a drug abuse warning network, that stopped collecting data in 2011, which is why you see that as a last thing. But you do see an association with opioid prescriptions and an increase in adverse health outcomes. But the point of this as well is that the great proportion of these patients that ended up overdosing, or the overwhelming majority, had a history of chronic pain. So going back to our patient. Patient is on morphine. Now that we are hopefully adequately treating his pain, let's address the diversion that we see here. So the patient was not aware that he was short on pills. He then remembers and tells you, my nephew was here the last month, and perhaps I can't imagine he would have done that but maybe he took some of my pills. I have no idea what has happened. So you go on to address this, and you ask, well, have you given your pain medications to anyone else, or have you received any from anyone else? And he goes on to tell you, oh, my nephew gave me these other pills one day that I was in pain, and I think it was hydrocodone. And so it's a perfect example of how diversion occurs through family members. Going back to risk assessment in the patient. So the first thought is when you see a patient come in who's short on opioids, you think that patient is abusing, not necessarily diversion. But how difficult is it to assess that? So it's not that primary care physicians or primary care prescribers are bad at that in particular. One study showed that in just under 400 patients, about 5% were incorrectly categorized as moderate to low risk, when in fact they were high risk. Or conversely, they were assessed incorrectly 95% of the time. So very difficult to pick out the quote-unquote stereotypical opioid abuser. Diversion is something I defined for you before, but I'll remind you, again, it's taking medication for which you have no prescription. Whether you've gotten that free, you bought that medication, or you stole the medication. So under the new definition of misuse from SAMHSA, in that annual survey that I mentioned, roughly over half of misusers, which includes abuse, get their opioid medication from a friend or a family member, whether free, bought, or stolen. However, not insignificantly, a little bit over a third get it from one doctor, and that could be one prescription or through multiple prescriptions. The survey that's done, by the way, or administered by SAMHSA, is roughly to 70,000 homes or individuals, for which they get about an 80% response rate. Included in the survey is the misuse of pain relievers, and this is where this data comes from. This is the latest data that was posted on SAMHSA as about a month ago. In another study, it was found that patients with an abuse code with no opioid prescription of their own, out of about 10,000 patients with abuse codes, 20% of them had no prescription. So it's 20% potential diversion. So they have an abuse code, but no prescription. They got the opioid from somewhere. About half of the 20% had a family member with an opioid prescription. So potential diversion from a family member. Get some more supportive data of diversion occurring. So now let's go back to the actual patient, or through abuse, through diversion. Either way, abuse typically starts by oral overconsumption of intact pills. The progression is from oral overconsumption, where they're whole or chewed, progressing on to then crushing in order to snort or to inject. So what's the significance of that? In one study, in just about a year and a half, in a subset of abusers who were in a substance abuse treatment center, progressed from mostly oral ingestion on the left, that big blue slice, to the right for the green slice, mostly to snorting, and the purple slice to injecting, and the blue oral ingestion, the minor route of abuse. So the major routes of abuse, or the progression to major routes of abuse, was from oral to non-oral in just about a year and a half in the subset of abusers. Now, you may notice that the ends are different. The left column is 112, and the right column is 133, which is simply the data that was available for those two cohorts. So there is progression. And why is that significant? The non-oral routes, including snorting, the green, and injecting in the purple, lead to fatalities or major life-threatening events more often than through oral ingestion, whether whole or chewed. At the end of the day, we don't only want to prevent overdose deaths, but we want to treat addiction, but we do want to deter that progression from oral to non-oral routes of abuse. So let's look at 3 different opioid molecules: oxycodone, oxymorphone, and morphine. And you can see that by far, oxymorphone is mainly snorted. Oxycodone and morphine are a little closer together in terms of oral and snorting. However, for morphine and oxycodone, injecting is not insignificant. So it's not that one route is necessarily more prevalent than the other. They occur at different rates based on the formulations that are available in the marketplace. So for morphine, the snorting is not insignificant, and the injecting is almost as much as the oral abuse, because some of the ER formulations for morphine were easier to defeat. And why is ER singled out in this slide? Well, ER versus IR has simply more opioid content, so you can get a faster, bigger, more intense high. So in terms of targeting opioid abuse, misuse, and abuse through diversion, what is a healthcare prescriber's role? You'll see on the green column, going from top to bottom, you have the use of risk assessment tools, which we use in our patient case, prescription drug monitoring program. What information do you get from P&P? Do you get the morphine milligram equivalents, or how many milligrams of morphine a day that the patient is taking, as well as how many prescriptions that patient has for opioids? There are urine drug tests, which may or may not be economically feasible, may not be practical from a time standpoint, and may provide stigma to the pain patient if not done on every patient for every visit. However, they have their own value as well. Other interventions include limiting the amount of morphine milligrams per day, doing spontaneous pill counts like we did in our patient case, asking them to come in and count opioid pills. Recovery program, which is really medication-assisted treatment programs like buprenorphine, naloxone, or methadone. And then pharmacological approaches, including abuse-deterrent opioids, and naloxone, which is really a last-ditch effort when someone has overdose in order to reverse their opioid ingestion. You then administer Narcan either out in the field or in the ER. Some states are allowing pharmacists to prescribe with any opioid prescription and to provide Narcan with the opioid. And we'll come back to that list in just a bit. So let's focus a little bit on abuse-deterrent opioids. I know they're a little bit of a black box. There's not a lot of education on them. So abuse-deterrent opioids, of which there are 7 approved, of those 7, there are 4 out in the market now, including ones that have morphine, oxycodone, and hydrocodone. They use different technologies, but by far, or those 7, it's really the top 2 technologies that you see here. This is from the FDA guidance on the evaluation of abuse-deterrent opioids. There's a physical-chemical barrier, which is difficult to crush and chew. You can imagine you can either chew it and ingest, or crush it to snort or inject, or both. Then there are agonist-antagonists, which include an opioid, and the antagonist either naltrexone or naloxone. So once that is manipulated, membranes in the pills or the pellets are broken, and both the opioid and the antagonist are released. The antagonist then attenuates or reverses the effects of the opioid, both pain-relieving effects and effects leading to euphoria, of course. So for abuse-deterrent opioids, there are 4 classes of studies, of which the first 3 are performed in order to characterize really how effective her abuse-deterrent properties are. And they include in vitro testing, in vivo testing, and clinical abuse potential studies. I know it's a lot to take in. Just keep in mind what you're trying to do through these studies is to manipulate the drug and then assess how the study participants feel taking the drug. In category 1, you're looking at how difficult it is to manipulate the drug, to cut it, to crush it, not necessarily chew it, but with household tools like, say, a hammer or a blender. In PK studies, you're looking at manipulated product and intact product to see about drug concentrations, and then you assess their rating of that drug. In clinical abuse potential studies, you're also looking at intact and manipulated product, and they're typically asked if they like the drug, how high they are, assuming that they are high on it, and if they would take the drug again. As a conglomeration, what this data is trying to get at is how effective these abuse-deterrent opioids are in reducing the liking of these products, of the high that these products may cause, and how they attenuate that high. At the end of the day, what they're trying to prevent is a high if they are manipulated, meaning crushed or chewed or dissolved. If taken whole intact, of course, they do not deter abuse and does not prevent anyone from taking 20 pills at a time and either getting high or overdosing and suffering adverse health outcomes of that overdose. Some of the labeling for these products is not in, it's not clear, so it's not an indication. It's in section 9. That's just for your own information because it's a little bit hidden. So let's go back to the patient case. This patient has back pain on morphine, minimum amount of 20 twice a day. But the patient did have some pills stolen and took some hydrocodone in return. So in a patient like this, what steps would you take now that you've found this out? What would you do about their opioid treatment? What other implementations or interventions would you use to try to reduce opioid abuse in this patient or any other patient in the practice? And currently, what are the interventions that you're utilizing in your practice? Let's go back to the list that I showed you before. So, Jim, I don't know if you can hear me, and perhaps we can try to unmute the participants to see if anyone would like to offer what interventions from this list in green are currently being utilized in their practice.
Okay, we can try to unmute, or we can also have people type. Either way. So
sure. Let's try typing, perhaps.
Yeah. Okay. So typing. We're working on typing. So there's a way to do that under chat, or there's a way to do that under question. Either way.
So as I let you guys type, and hopefully we'll have one brave soul that will tell us what interventions that are aimed at reducing opioid abuse in the practice are currently utilized in their practice.
So pill counts, it's just popped up.
Mm-hmm.
Right? Gloria says pill count.
Great. Is anyone currently employing prescription drug monitoring checks for every patient and for every visit? Maybe a simple yes would do.
Right. Let me just read these as they've come through. Can you hear me all right?
Yeah, absolutely.
Okay, so one says treatment agreement, risk assessment, and pill counts. Then I'm not sure I'm interpreting this correctly because I'm not in healthcare, but it's spelled I limited and then RX. So I'm
I see. Perhaps
someone did. Yeah, and then someone did answer you yes. So an answer to one of your questions is yes. So
Is anyone utilizing urine drug tests for every patient for every visit?
So one answerer says no. I'm only putting that one at the moment.
Another question would be, if in anyone's practice, is there use of any abuse-deterrent opioid in terms of pharmacologic intervention? And I'll list out I said I wouldn't mention by brand, but this may be easier this way. So for ADOs that are currently on the market and FDA approved, it's Embeda, Hysingla, OxyContin, and Xtampza. So curious to see if anyone is using abuse-deterrent opioids in the chronic pain population. I suppose conversely you can type no.
There is one answer that says OxyContin.
Mm-hmm. And it'd be interesting to find out if it was a reformulated OxyContin or the OxyContin prior to 2010 that is not an abuse-deterrent opioid. Anyway, thanks for that participation, and thanks, Jim, for letting me know. So I would urge you to have this conversation in your clinic, in your hospital system, not just about abuse-deterrent opioids, but this whole list that you see in green, risk assessment tools, which could be easily implemented while the patients are waiting to see the prescriber in the waiting room, PD&P checks, UDT screens or urine drug test screens, of course treatment agreements, I'm sure utilized widely, limited prescriptions by default, by far, for chronic pain patients are limited to 30 days. For acute pain, there's overprescribing, but at least one state, Massachusetts, has now limited the supply for acute pain for prescription for just 7 days. I know when I went over my brother's house about 2 to 3 months ago, he's post right shoulder surgery, otherwise healthy 50-year-old, and they showed me the opioid medication that he had in his medicine cabinet. He took 3 pills. He didn't feel that great on those. He left the other 57 pills there in his medication cabinet for me to see. So he then suspected that his baby brother, namely me, could have taken those pills, sold them, or abused them myself, and that would be diversion. So you see how overprescribing acutely can increase the risk of diversion and subsequent selling of these drugs to someone who will abuse, or diversion leading to abuse directly. All of these interventions in green are listed in the CDC opioid guidelines for your reference. And in terms of abuse-deterrent opioid literature, because it's limited in the guideline, I would just Google abuse-deterrent opioids, and you would get the 4 that are currently marketed. Okay, well, I'd like to open it up to general questions or questions on anything in the deck. I'd be happy to address.
All right, everyone, we can try this by typing first, I think, and I'll do my best, or if you would like me to unmute you, by all means, raise your hand, and I will be glad to unmute you. Look for at this moment, I don't see any hands raised, and I'm still looking for questions.
Okay.
I do not see questions.
Okay, well, no problem at all. I did mention the cash prize for the first one to ask a question. Well, just kidding. I don't want to put Jim on the spot.
Hang on. There is a question. Hold on just a moment. Get back up to it. It says, do you know of studies done on cancer patients?
So the CDC opioid prescribing guidelines is strictly for non-cancer chronic pain. And if you're asking for studies done on cancer patients, it's going to be difficult. And that's because at some point, chronic pain studies have to have a placebo arm. And it's just simply not ethical to put a cancer patient on placebo. Even if you did attempt to do that, there'll be massive dropout from that placebo arm. Typically, rescue medication for pain in chronic pain studies, which, by the way, don't last much more than 12 weeks. And why is that? Well, the reason I just mentioned. There's typically a placebo arm or cohort, and the rescue medication is Tylenol maybe 3 to 4 times a day. So you can imagine if you're on chronic opioid therapy, that Tylenol will not do its job as rescue medication, and you'll drop out of the study. So for chronic pain, typically what is done is the patient is given whatever pain treatment they require and whatever opioid milligram or morphine milligram equivalents that they require per day.
Great, thank you. Are there other questions for Mario? I didn't see any additional ones added. Let me come back up and check to see if anyone has raised a hand. I do not see any hands raised. Looking back down for questions. Mario, I don't see any additional questions.
Okay, well, no worries at all, Jim. I hope that the lecture or the content was valuable. I hope it was new data and new information. And thank you for having me, Jim. And I'd like to thank the National Hispanic Nurses Association and, of course, Pfizer for sponsoring this lecture, this webinar.
Yes, indeed. Thank you, Mario, and thank you, Pfizer, as well. And thank you, everyone, for tuning into this webinar, and we will conclude now. Thanks very much, and have a good evening.
Have a good night, all. Thank you.